So, officially done with my first month of residency. The very first month throughout basically July was kind of just mostly orientation stuff, so there wasn't really like a lot to per se talk about. We just really went around in different parts of the hospital learning about different things. Now, we're literally in what is basically the official month of residency, and that was all inpatient medicine for me. So I was a hospitalist, and I was running around all over the place trying to get everyone to be as healthy as possible. What did that entail? Well, I talked about last time, I talked about up to here, right? So what I had really done up to that point was kind of night shift, where my job was to take care of everyone that the day shift had managed and do whatever the patient might need overnight. Okay, so as a night shift family medicine resident, you take care of the inpatient patients as well as the inpatient pediatrics patients and the newborns, right? So if any kids are born overnight, and that was interesting. It was great, but I wasn't really taking care of or treating anything. I was just holding them through the night, which often involved putting in hydroxyzine or melatonin and really just helping patients kind of fall asleep, stay rested, right? But there was a lot I didn't know at that time. We had some patients that were COPD, there were patients who had heart failure. There are so many other things that I could have ordered or put into place, or the day team could have put into place, that would have really brought much more peace and patience to all the patients. So this last 2 weeks, right? So we left off here. Then after that clinic day, I had 1, 2, 3, 4, 5 days of inpatient medicine. Went off a day, then again clinic, and then once again 5 more days of inpatient medicine. So that's 10 days right there. And then last week, right, was kind of really going through inpatient medicine nonstop for 6 days in a row. And today we're here. So that's kind of my day off, right? So here we're on the 31st, my day off. So it's been pretty rough in the sense that I went through a lot of, like, essentially, I think this was be titled 7, 8, and 9, week 7, 8, and 9. So I'll update that. But going through all those weeks of inpatient medicine, 3 weeks in a row, I picked up so much, right? Because we have different attendings. So we have one attending who has a style that's all hospitalists, so he's there all day. We do table rounds first, and then we go see the patients. Then we'll talk about everything again, and then in the afternoon we'll once again talk about things. This particular attending also likes to teach a lot of hands-on ultrasound. So we use a portable ultrasound device to kind of practice on each other, finding the lungs, finding the sliding parts of the lungs. We look at the liver, we try to find the kidneys. We've used it to find vessels on the legs, tibial artery, popliteal artery from behind the knee. And we've even used it to kind of make sure we can see the carotid as well. And these things are really to help us better understand anatomy, but also be able to do what needs to be done and also be able to order what needs to be ordered, right? So if someone might have a bruit in their carotid artery, for example, we can do an ultrasound and kind of see it, right? If there's a plaque there. Now, that being said, there was a lot that resembled step 3. We're putting in orders for consults. So if someone comes in with a GI issue, I'm going to be going ahead to consult gastroenterology. If there's, of course, one of the most common ones, chest pain or any kind of syncope, then we start kind of thinking about consulting cardiology and neurology, getting all these orders in for an echo, stress test, right, stuff like that. And really doing like a step-by-step evaluation of a patient, where if everything comes out normal to a certain point, we don't even do the rest of the evaluation, because it might have been a one-off kind of event. And if the patient's feeling really well in the 1 to 2 days they've been there, then we just educate them, really have them understand what's happening, and then send them home. Now, sometimes we get more critical patients, right? There have been a few patients we had that had alcohol withdrawal, and now you have to start calculating CWA scores, put them on a Librium taper, a lot of which many students, especially IMGs, don't really know about, managing alcohol withdrawal within American hospitals. And it's kind of a difficult position to be in, because withdrawal symptoms can get really intense for a lot of patients. And if it gets to a certain point where SIBO scores are more than 15, 20, maybe the patient has a risk of seizure, then sometimes they have to be in the ICU for a while and really get like intensive care and be monitored very closely. But when they come onto the floors and it's under your hands, it's going to be a step-by-step progression towards really making sure that you handle their withdrawal symptoms, but you also make them feel better as time goes, managing their nausea, managing any hallucinations they might be having, and really just taking care of their agitation overnight too. So it's a lot of psych meds. And of course working closely with the psych team as needed. Then we had 2 patients on the same exact week, pretty much the same age, around 74, 73, and they both came in with gallstone pancreatitis, right? So they were both older, obese women who over time ended up accumulating some gallstones, and then it's not a fun thing to have because it hurts when the gallstone is in there and you're kind of eating and contracting your gallbladder. But then it's even worse when that one stone kind of comes down and gets stuck further down and causes pancreatitis symptoms. Now at that point, it's kind of an end the game situation because the patient comes in with extreme pain, a lot of pancreatitis symptoms, and you consult surgery, right? So now the surgery team is going to hang out. They'll see if it's emergent or not. And most cases of gallstone pancreatitis are kind of like elective cholecystectomy. You can't really do surgery at the moment when the pancreatitis is happening because everything's hot and inflamed, literally, right? So when there's all that inflammation happening, you can't really do the surgery. So as the hospitalist team, we're kind of there to simmer down the inflammation, right? So that really involves patients going to be NPO, patients going to be getting minimal food intake, and really just getting medication that's going to help them manage their pain. Eventually, the inflammation goes away, the pain simmers down, and then the patient goes and gets surgery. And in these 2 scenarios both, it was just a cholecystectomy. Now I got to be there, and that's going to be the screensaver for this exact video. I got to attend, just because I really wanted to, the robotic surgery of a cholecystectomy, and it was pretty cool because there was this one big robot piece that had like 5 arms to it, and for each of the arms there was another attachment. The attachments went into the patient first. So like if we're looking at their waistline where the belt would be, the surgeon made about 4 incisions, put in the first part of the arm, which would kind of be like the distal phalanx essentially, and then the distal phalanx kind of attached onto the 5 arms of the robot, right? So now the robot can move, and the 5 pieces are already inside the patient's abdomen essentially, and they're all kind of pointing towards the gallbladder. And the surgeon sits on a console that kind of, again, just looks like a video game console. And there's 2 of them looking like kind of sitting in front of each other. So there's 2 seats looking in front of each other, and they have like a console to look into and controls to it. And I guess if there was a much more intensive surgery happening where 2 surgeons are needed, they could both sit on their own ends and kind of collaborate together to do the surgery. A cholecystectomy is a significantly easier surgery. You don't even really need all of this, but the robot just makes it much more easy to do a less invasive surgery, right? So those 4 arms also have like a tiny thing that would come out of it, and then it would be able to burn and cut off all the correct parts to just remove the gallbladder and take it out, send it to pathology, see what kind of stones are in there, how many stones are in there, stuff like that. Very fun to kind of really be there and witness all of that with the surgeon and the rest of the team, and then see the patient recover. I had that same patient for the whole week, minus the one day I was off, the one day I was in clinic, where on weekends, a lot of hospitals, especially in Ogden, don't really do too much. So when I came back, the patient was still there. I got to go to their surgery. I got to watch them recover. The recovery phase was all about pain management, right? And really making sure that they get to defecate, that they can urinate fine, that they can walk around fine, which are often, for almost all patients, you're going to be ordering PT and OT consults, right? You really need to make sure that physical therapy, occupational therapy, they come on in and they meet the patient, walk them around, make sure that their pain is tolerable levels, and then putting the patient on pain medication that they can actually take at home, right? So they're not going to be getting morphine injections or getting any hydroxycodone, or of course definitely not fentanyl, because this is basically the ladder at which they keep getting stronger, right? And they can't have these things at home, so you try to treat their pain without these things. maybe lidocaine patches, which can also be purchased outside, and then really just pain management with like Tylenol. Now, in my last week, I learned that, a lot of patients will come in with a lot of chest pain, cough, stuff like that. Overnight, you want your patients to sleep well, right? So that would mean putting scheduled hydroxyzine, putting scheduled Tylenol, not PRN, where they're just going to ask for it when they need it. No, keep giving it to them, right? Give them the hydroxyzine low dose, give them the sufficient dose of Tylenol depending on whatever is causing their pain. Give them cough syrup at night so they're not coughing and not waking up from their sleep due to cough, right? And really just maintain your patient's comfort, because that is what's going to help them recover, right? During the day, you offer treatment. So you might be giving expectorants to patients who have pneumonia to help them cough it all out. You might have to do a procedure at some point and make a patient NPO during the day. So they're not going to be very fun or having a lot of fun or very happy during the day. So you really want to make sure you do the best to keep their night as peaceful as possible, right? A well-rested patient will be much more collaborative with you and cooperative to really kind of do what needs to be done during the day for their treatment. Now, ordering diets is another big deal, right? You need to consult nutrition, make sure that the nutrition team can kind of see if the patient might need Ensure or anything other added to their multiple meals throughout the day. And also figure out whether or not your patient can swallow correctly, right? If the patient needs a dysphagia evaluation, if the patient had a stroke, there might be some risk of patient not being able to swallow correctly. So you have to order different types of foods that are going to be much more easy to swallow, right? Some foods have more liquidness to it, right? Liquidity, and some other foods are kind of more like mashed up. So these things all fall into consideration. So when you sit down to admit a patient, top to bottom, one of the first things you do is you put in all their home medications, right? So whatever they take at home. For hypertension, maybe they're on lisinopril. For their allergies, they might be taking Zyrtec. So you put all those home meds in. This gets a little tricky when it comes to diabetes, because the best thing to put patients on usually is a sliding scale, right? You put the Lantus in, you put in insulin injections and get them going on that, because you don't really want to give metformin to patients in a hospital. There's some level of possibility of causing lactic acidosis on metformin, and then lactate often triggers a sepsis scare, so you avoid that. And then glyburide and all of those class of medications, right, they're also not exactly the best thing to give inpatient. So you hold those home meds and you just replace diabetes management with a insulin scale and put in sugar as needed too, just in case they become hypoglycemic at some point, right? One of the biggest scares of managing sugar in an elderly patient. Now, same thing with the hypertension medications. You want to put holds on them where you tell the administration instruction that if you're going to be taking this hypertension medication, do a blood pressure check first, because if your blood pressure is below a certain level, you don't need to take it, right? Now, patients who are admitted often will have hypotension because they're just sitting there. They're not really doing anything. They're completely relaxed. They don't have to worry about work or the stressors of family or anything else, really. And other times, patients might be very stressed out, very anxious, so their blood pressure might be very high, so they might need more than their usual doses of home medications for blood pressure management. So these are some things you pay attention to. Once the home meds are in, you kind of figure out what you're going to give them for their diet. It might be NPO, if you know that they're about to go through some kind of surgery or they're about to have some kind of test that requires being NPO, like a colonoscopy. It might be something light, like full liquids, because they might have had pancreatitis, right? Or it might be a full, regular, unrestricted diet where they can eat everything and anything because they're really not affected by the food intake. It's something else. Other times, you're going to have to figure out what are you going to consult, right? Are you going to consult gastroenterology, cardiology, neurology, etc., etc.? For almost everyone, you put in a note for PTOT as well, where they understand that this is a patient who's eventually going to need PTOT, physical therapy, and then figure out what their notes are going to say, because PTOT is like one of the closest friends for you. They're going to make sure your patient can walk. If your patient can't walk, they shouldn't be going home, and they're going to put in a note saying that this patient should go to short-term rehab, or this patient should have home health, or this patient should have home PTOT, etc., etc. And based off of their recommendations, that's exactly where your discharge plan is going to be. Now, if the patient needs to go to short-term rehab, you have to get involved with the hospital floor case management and social work. Those two are also very successfully helpful buddies of yours that are going to kind of establish what's going to work out, right? What short-term rehab facility are they going to go to? How are they going to pay for it? And their notes are really going to tell you a lot too, because their notes often include who does the patient live with, what is their house situation, what is their financial situation, things that you need to know about before you discharge a patient, because you don't want to discharge someone that comes back. That often will ding a hospital for quite a fee, right? Hospitals lose a lot of money if they discharge someone and that same patient gets readmitted again within a certain period of time. Now, it's okay if you discharge someone for chest pain and then they came back because the next day they were in a car accident or they fell and fractured their ankle, because those two are completely different scenarios. But if the patient gets discharged and comes back for the same exact thing, that's not good, right? And then now it's basically a sign that you didn't treat it correctly the very first time, and you have to work on that. So that ends up being very difficult. And I got to see a lot of all of that, and it was very intense, but very fun. As you continue putting in orders, you're going to figure out your pain management, right? So your patient might have pain at different times or have a headache, right? So Tylenol is usually one of the things. Now you could put Tylenol PRN, or you could just schedule the patient to get Tylenol nonstop every 6 hours, depending on what's wrong with them. You can also schedule Tylenol for 24 hours to keep giving it to them every 6 hours, and then after that make it PRN and give it to them as needed. Or you could start looking at whether or not the patient is going to need opioid treatment, right? Depending on what might have happened to them. They might need morphine injections for breakthrough pain. They might need hydroxycodone and Norco and all those other medications that are much stronger, depending on whether or not it was a fracture they're going through. Maybe they broke ribs, maybe they have a broken leg, things like that. When it comes to orthopedic nature, you really need much stronger pain control, right? Musculoskeletal pain is very problematic. You could put patients on things like Flexeril, cyclobenzaprine, and whatnot, muscle relaxants, which will both help them fall asleep as well as kind of bring relaxation to their pain. And then you keep going. Now you need a bowel management, right? So if the patient is constipated or having diarrhea, you need to figure out which one of the two and put in some medications for that. Miralax, Colace for the constipation. If they're having diarrhea, you put in the appropriate things for that as well. And you keep going. You kind of think of every single thing that the patient might need and put these in. Before nurses ping you telling you, hey, the patient's having X, Y, and Z, can you put it in order for something? When these events occur, where nurses have to message you to tell you, hey, the patient's having pain, can you put in Tylenol? They don't have anything for pain. It just makes you look bad. And nurses are very good at remembering who they had to message. So they'll know if you're the one that's kind of admitting patients on a given week. They already feel like they have to message you all these things and teach you the things you need to order, and that's not going to go very well. So you kind of want to make sure that you put in everything the best you can before, basically proactively. And speaking of nurses, it's so critical to spend time talking to them, memorizing their names, using their names, and then also sharing the general plan that you have for your patients with the nurse, right? So when you're there on the floor and you're done seeing all the patients, kind of try to spend about 5 minutes huddling up with the specific nurses that are managing those patients. Now, if the same nurse is managing 2 to 3 patients you have on a given floor, beautiful. But if it's 2 different nurses, you go and meet them because you have to, independently, and really let them know, like, okay, so for this patient, I'm going to put in Tylenol and Colace and Miralax, and we're going to give them X, Y, and Z as well, and the plan is to kind of do an echo tomorrow, so we'll keep them on a full unrestricted diet for now, make them NPO at midnight, blah, 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 stuff like that. You let them know they feel more involved, they feel better, they feel that they're under the hands of a talented physician who knows what they're doing. And it just brings you peace too, because they won't be messaging you regarding something because nothing got missed anymore. And if there is something, right, that you may have missed because you were only with the patient for a certain amount of time, the nurse will tell you, that, oh, the patient was vomiting a lot. So now you need to put in, with the same thing with the bowel regimen, nausea regimen, right? You need to have something there, Phenergan, ondansetron, etc., to make sure that the patient will be taken care of if they're going to be feeling nauseous. If your patient is nauseous, that means they're not going to eat. If they're not going to eat well, they might end up vomiting too, which is only going to end up taking away a lot of comfort from them, making them much less stable and making their recovery highly unlikely, right? So it's a kind of a tough place to be in when that happens. Ultimately, all these lessons came together and ended up making me, in my last week of inpatient this month, feeling significantly more improved. Learning these things is something that next time I do MedF, which is going to be in December, I'm going to be much more ready and hands-on and kind of thinking about the patient in a way where I know what I need to do step by step to bring them from the position they're in when they first came to where I need them to be when they're at discharge. All right. My next rotation, this residency, PGY1, is going to be pediatrics. So during pediatrics, I'm going to have 2 weeks of nights. So I'm going to be handling both MedF and peds, and I'm going to try to go live from the evening sessions and really just talk about things that are happening. We don't really discuss patients there. It's a safe environment. And then really share what else is significant in terms of ordering, right? What's been happening in my growth process and the rest of what's to come for all of you that may even be applying for the upcoming match, right? So there's a lot to talk about in that aspect, and it's really been a pleasure sharing my journey as we keep going, really seeing myself grow, telling you guys about my growth, and kind of just evaluating myself day by day, week by week, every time I go live here to talk about things, because it reminds me of how much I knew the last time I was live with you all and how much more I know now. And next month, doing a whole month of peds where I'll be taking care of newborns, evaluating them, doing their bilirubin test, sending them home, as well as taking care of toddlers and children under 16. So we get 10-year-olds and 14-year-olds with different scenarios, nothing extremely critical. Really shows how much more I start growing, right? Because I'm going to learn different medications to order for them, different regimen to carry out for them, and really just take care of scenarios that are often very difficult, not just for the child, but the parents too, right? That's one of the most problematic parts in peds, right? Because you have to really make sure parents are good, and if the parents are not good, parents are not doing well, then the child will never do well, and oftentimes Child Protective Services have to get involved. So more on that as we get there, but thanks for